So we're going to move to the next speaker now, and as we knew, within weeks of moving to a level 4, nurses were calling out that the PPE seemed to be variable and access to adequate quality PPE gear was at times limited. So we're fortunate to have the Auditor General come and present, and this is a live stream. There unfortunately are no opportunities for questions and answers, but I'd like to welcome John Ryan, the Auditor General.
I'm just hoping you can hear me because there's things flashing up on my screen, which always makes me slightly nervous, but I'll keep talking. In the room with me today, I have Helen Colebrook, who wrote the report that we issued on PPE a couple of months back, and Greg Golding, who's our sector manager for health. So if there are questions, we can take them, but I recognise time is of the essence here. The Controller and Auditor General role, if you ever want to distance yourself from social interaction, call yourself the Controller and Auditor General. It's a role that's not widely understood and certainly doesn't attract many friends, but the key element of the role actually is that my job is entirely independent of the government. And my role is to look in on what the government does and its use of resources. And that's a very wide brief. So it obviously has a strong financial bent in financial audit, but we can look at the effectiveness and efficiency of government quite broadly. In the health sector, we've looked at things in the past, virtual care in Waikato DHB. We've looked at holiday pay, which is an ongoing issue we know for many in the health sector, and we've also looked at currently looking at the financial resilience of DHBs. But we particularly were interested in PPE as the COVID pandemic accelerated, because we think in our brand as improving trust, promoting value, we think that actually at times of crisis people need absolute confidence in the public systems that are set up to support. And so that's the angle we took. We wanted to understand what was going on and to ensure that people had confidence in the systems that were there to protect them. There is a full report on our website, and I'm sure if you've got any shortage of holiday reading, it's one you might want to put on your list. It's a very accessible and relatively easy read. So why did we get involved? The first thing I'd say is there were serious questions in our mind about PPE supply, and we, like others, were hearing a variety of stories. Community-based health providers, disability support workers, community midwives, primary care, residential carers were raising issues. National organisations that provided support were getting different stories, it seemed, from different DHBs. Private providers and others wanting, who were essential workers, were also asking questions about where to get PPE. And there was a lot of information coming to us and in the media generally, and I'm sure you experienced it firsthand, just about the clarity of what was going on, and the stories that we were hearing publicly were sometimes different to what feedback people were giving us. Even though we were locked down at the time, we felt it was important for us to get quite involved in this issue. So we wanted to do the report quickly, and we wanted to get our information out so it could be acted on while the crisis of COVID was still, able to be responded to, and improvements made if there were some to be made. We focused on the Ministry of Health and 5 DHBs who were involved in the supply chain particularly. We looked at PPE, although there were questions early on about ventilators and other health equipment that might have been needed, but PPE was where we took our focus. And obviously we're not clinicians, and so we didn't look to judge the clinical guidance, but we were extremely conscious that clinical guidance is what drives the need for PPE ultimately, and that was an important connection that we needed to look at. I would say at the outset that the Ministry of Health was extremely open to the work that we were doing. So even though they were, as everybody was, in the middle of a pandemic, and they were working day and night, they were interested to have us involved because we bring that independent line of sight. And if there were things that could be improved, they were interested in us improving them or making recommendations for improvement. And that was a theme throughout the review, that the Ministry and the DHBs, even though the crisis was in full swing when we were doing this work, were open to our work. So the first thing we looked at is what plans had been put in place for a pandemic and the robustness of those plans. And following the SARS crisis and following H5N1 avian flu, the Ministry did put in place plans, as did the DHBs, to respond to a pandemic. They also put in place a national reserve supply of PPE and other equipment which might be needed if a pandemic arose. And they contracted a local face mask manufacturer to provide masks in the event of a pandemic and normally. But it would be fair to say these were put in place in the between 2004, 5, 10, that sort of period. But COVID-19 has really been the first real test of those plans. And what we found when we looked at them and looked at how they'd operated, if you like, through the pandemic, was that there were it wasn't clear how the plans were to operate in detail. So it's, I guess, one thing to put a plan in place, it's another to make sure that in detail they operate. Some plans were out of date and hadn't been checked by the Ministry. And there was misalignment between what the DHB's plans were there to deliver and what the Ministry had assumed. So some of the plans didn't just fit together as you'd expect for an integrated system. There are assumptions in the plans around procurement and distribution, how they would work in a pandemic that proved not to be able to operate in the scale of the pandemic we had. And we thought that there were roles and responsibilities within those plans that weren't clear enough to be able to for people to stand up and operate quickly in that situation. And one of the findings in the plan was, even though there was planning in place and national reserve supply, they hadn't really got in place systems to predict the demand and how the stock would be managed in a high demand situation. I would say that we're not in the report at all critical of things like the number of DHBs or those matters. Really, it's about planning and the clarity of planning between the Ministry and DHBs and the broader health sector. So the first thing we saw was the plans were in place, but they did prove to be inadequate under the COVID situation. The first thing that you want to know in a national crisis is that you have a national response. And in terms of procurement, before COVID came along, most DHBs either procured their PPE stock themselves, or they worked in regional groupings to supply PPE. In a pandemic where supply and distribution worldwide dried up, this system just couldn't work, and it was constrained nationally and internationally. And suppliers were getting multiple orders from DHBs, and they were finding it difficult to prioritise those orders or know who to supply first. And of course, during this time, clinical guidance changed quite regularly through the early phases, in particular the pandemic. The Ministry, in terms of procurement, recognised this really reasonably early on and moved to centralise their systems of procurement. I think at the end of March or early April, they put those in place. And they also recognised that they were being turned to by not just health system, but the whole country was turning its mind to PPE and were looking at the Ministry and others to supply PPE. So they set up a system that wasn't just for health, they also considered how private providers and others outside the health system completely could get PPE. We make a recommendation report and critical that this should have been anticipated and set up sooner, but it did get put in place pretty early on and did prove to be reasonably effective when it was working. Under stock management, the National Reserve supply was a bit problematic. When the pandemic struck, the Ministry in February, for example, didn't know how much PPE was held in the National Reserve supply in total. They knew what they held, but some of it was also held by DHBs. and they didn't know that. So you didn't know your full stock. And then it took some time to get accurate information on how much stock was available, partly because the systems had previously been in place up to 2016 to report on stock levels to the ministry. So they did have a view then, but subsequently that was found that stopped happening, and at the time of the pandemic they didn't have accurate information. And it took them till April to get that because there were issues with the information flows. When they did get the information, a number of DHBs reported that their stock was out of date or had expired. So there were weaknesses in stock management as well. And of course, when it was set up back in I think it was about 2005, it was based on population assumptions at that time. So the National Reserve supply was based on a population that was something like 19% smaller than we had when the pandemic struck. So clearly both these areas were areas where we thought there was need for quite considerable improvements. The most basic thing is to know your stock, to know what condition it's in, and I think the ministry's taken that on board wholeheartedly and are working pretty hard now to make sure that that doesn't recur, and they've got a way forward. The next area that I just wanted to highlight was that clinical guidance, as you know much better than me, drives the demand for PPE, and that changed regularly throughout the initial phases of the COVID response, which we looked at. Some of that based on international guidance changes. Everyone I think was working through that on a world scale, and some of it because of local conditions and local input. These changes did, though, cause a level of confusion, I think, both in the core health sector and beyond it. And of course, clinical guidance drives the volume of PPE that you need, and as I mentioned earlier, there was no real model for making those two things fit together. There were some public statements, and one we highlight in our report was from the Director General of Health, where he said at one point that people not only need to be safe, but to feel safe, but that they also need to act in consistency with clinical guidance. Unfortunately, I think that probably was quite a difficult message to understand clearly, and what that meant was a lot of demand then came from people who felt that they wanted PPE, even though the clinical guidance didn't necessarily require it, and that the DG of Health had actually mandated that to happen. So we saw a lot of confusion after that. On the same day that occurred, I think it was, or certainly within a couple of days of it, all the DHBs were then asked to distribute PPE to community providers in their areas. And so two things really happened. One was we had this increase in demand as a result of that communication and the expectations around that. And the second was DHBs don't have relationships, as you would know, with every community provider in their region. And so some of those relationships are direct with Ministry of Health, some ACC, others I'm sure. And so they had to form new relationships. They were getting orders coming into them, and they didn't necessarily have the stock to supply. So that's where national organisations started to see different responses from different DHBs. And found it quite difficult and confusing as to what the situation was at that time. So we've made recommendations in our report about how you should flow clinical guidance into the broader supply system, and in particular the clarity of communication around clinical guidance. The ministry put it on their website and distributed it to DHBs, but they actually, we thought, needed to be much more proactive in distributing the guidance. The next point we made, this is the point I made earlier on about clarity of roles and responsibilities. When you go through COVID, you realise that who might need PPE in a pandemic is probably a little bit different to what you might have thought of when you were thinking about a pandemic. So obviously DHBs, health providers in the broader community, primary care, but then you get into corrections, police, and of course supermarket workers were essential workers as well. And at various times, all of those turned their mind to getting supply from the National Reserve supply, which it hadn't been set up for. Initially, it was set up for DHBs for their own use. Then it got extended into a broader community focus, but then inside the health system and then beyond as well. Who should provide PPE in a crisis? Should it always be the Ministry of Health? Should private providers under the Health and Safety Act, as they have responsibilities now, be required to do that? How do the systems behind each of those work? What should be in a national reserve supply? What volumes, what period of time should it be there to support people, and who it should port are all critical. And I think we make the point that it was quite fundamental to drive clarity in those messages early, so that we could everyone can be clear on what's required. Finally, I just make the point, as I made at the start, that this was not done to the ministry. It was done independently by us, but with a lot of support for the review from the ministry. The country has largely been successful in managing the worst ravages of this disease. And so it's in that context that we made, I think, 10 recommendations in our report. We also made the point, as it proved to be true, that we weren't out of the woods at that point either. And so action needed to be taken quickly. The Ministry has agreed to address all the recommendations in our report, and we're confident that they're underway on those. And we will be keeping an eye on that to make sure those get embedded thoroughly at the end of the next period that they're working on. We'll be keeping a watch, is basically the key message I would leave you with. So thank you. That was my presentation, and I think there's probably a minute if there is a question, but otherwise I'm happy to stop.
Thank you very much. We've got quite a few questions. That's how popular your independence has been around this. But I wonder if we take the first one, and then if you possibly can answer the questions in the chat, so that we could, if that would work. But I'll do the first question if I can, which is, can you speak to the testing that was done for expired PPE that was deemed it's safe for use post-expiration date? In Canterbury Primary Health Care, staff and those doing swabs had surgical masks that were expired, but in the District Health Board, staff in areas not in contact with COVID patients had masks that were in date.
I was aware of that issue. I think I said at the start that we're not clinicians, and we were careful to review the things that we've got expertise in. So procurement, stock management, how clinical guidance fed into demand and those matters. But we did not and would not be competent to look at some of that clinical guidance that was given to staff. We were aware of that issue. We did look broadly at when stock was coming from new suppliers into the system, whether that was how they managed that through the emergency, where they had to use new suppliers. But we haven't looked on the ground at how particular clinical guidance was applied in a DHB or any other setting.
Okay. So I'll leave these questions in the chat line if it would be okay, if you could, we could try and work out some response so that members could see what that would look like. I think the emphasis is about nurses feeling safe and being safe where they were at work, and I think what we overwhelmingly heard that there was patchy at best in some of the areas across the health sector. But I want to thank you very much for the opportunity for our members to share in this discussion, and I'm sure that there will be many more questions. Thank you.
Happy to respond to those over time. Thank you very much.
Thanks.
Appreciate it.